the prof appointment, what, next month or when? When you are starting the prof appointment?
This month 29, sir.
29, yeah. So now, at the end, you have to have the evaluation. So if you look at the evaluation, you will find it's 40% for theory, 40% for clinicals, and 20% for the continuous assessment. So theory is, of course, SCQ and MCQ, and then long case and short cases. Now, you have to get at least 40% in the clinical, and you have to get at least 50%, 40% in the theory and at least 50% in the clinical, and more than 50% combined to pass. So there are a small number of people who always fail in spite of getting good theory marks. They fail because they fail the clinical. Now in the clinical, out of the 40, 20 marks goes for the long case, where you half sentence is to get specific instructions, and you are supposed to examine, and we are watching how you examine, and for your general approach and technique, you'll get marks. For the positive signs, you will get marks. Then, of course, if you find wrong positive signs, you will reduce some marks. And then whatever the physical signs you find, you are supposed to interpret it in the given context. For that interpretation, you get marks. Really speaking, in the long case, most people are able to get more than 50. Very rarely only people get less than 50 in the long case. Actually, if you get less than 50 in the long case, very difficult for you to get through, because if you get 40 in the long case, you have to get an average of 60 in the short cases. And that's pretty difficult, especially in the two cases. I mean, like, people who are absolutely thorough with their clinical examination and all, it's okay. But for most people to get 60 average in the short case is pretty difficult. So therefore, you have to really concentrate on the short cases. So that is during your appointment, in the provisional appointment, what happens is the consultants will really be doing mainly ward round teaching and, history taking and things like that. But there is supposed to be, especially in the afternoon, more classes about how to examine a particular system and how to present and all, usually done by registrars. Sometimes Dr. Mali and all will do that kind of class. But even if that is not done, you are supposed to practice and get ready for that, because that is an important area. So that is just an opening to justify a kind of teaching that I have been doing with all these batches over the years, which is called slide teaching, which is what I'm going to do now. Now, slide teaching is based on clinical sites of patients that I have accumulated over the last virtually 50 years, like from the time I became a lecturer in the medical faculty in Colombo. So there are, of course, some of the slides are of very poor quality and some are of good quality. And also, I use some teaching slides again from a set of slides I was given by UK Save the Children Fund, which are teaching slides prepared from clinical patients from all over the world for teaching purposes. So there is a mixture of these two sets of slides in my slide shows. So that's it. So I use it because one of the severe deficiencies that you all have, and that deficiency is going to get very much worse with the plethora of medical schools that are trying to open, because your access to patients is the thing that is critical. And merely having a prof unit hospital for prof unit is not enough. You should have had access to hospitals with a good number of patient turnover right through your training. So I don't know to what extent you have had that. But what I know is most people compared with, say, our time have not seen even 50% of the kind of patients that we have seen. So you have to actively take steps to reduce that gap, by looking at clinical pictures and of course seeing as many patients as possible. So not only in pediatrics, the patients that you see are in all your appointments, whether it's orthopedics or ENT or whatever it is. All right, but did you all hear my comments?
Yes, sir.
Yeah, okay. All right. Now, so what I do now is I give a brief clinical history if necessary, or I give the same instructions that as I would give in a real short case and expect you to answer. So how fast we can proceed will depend on your response. So please, there is absolutely no shame in making a mistake. I'm not going to ridicule you or something like that. So please don't delay by not responding. And I don't have the time to identify people and ask. So you all can respond freely, but let everybody participate. So we are starting with a very easy one. Now this is something you will definitely get in your short cases. Now in this particular instance, you may not actually get a history. Depending on how obvious the abnormality is and where the girl is behaving at that time, you might be just told, please observe this child's face and tell me whether you can find any abnormality. Or you might be given a specific instruction, which I won't mention at the moment. So I'll leave it that please observe this child's face and tell me what you can see. So you mustn't straight away come out with a diagnosis. You have to describe what you see and then use what you saw to arrive at the diagnosis. So we'll start like that. Can someone answer? What can you see in this clinical picture? Don't waste time. Huh?
The facial folds on the right side is absent.
Yeah, okay, very good. That's an extremely good answer. You can see there is an asymmetry in this face, that the nasolabial fold, she called it the facial fold, is very marked. Come on, I don't know why it is on the left side, but is completely absent on the right side. Very good. So what does that suggest to you? What does that suggest to you? Yeah, go ahead.
Probably a right lower motor facial motor neuron palsy.
Okay, why did you straight away say lower motor neuron? Why did you said right lower motor neuron facial palsy? Your answer is actually correct. But then can you justify the lower motor neuron part? Why did you say lower motor neuron?
The facial folds on the upper on above the eyebrows are missing as well, sir.
All right. She's not wrinkling the forehead or anything like that to see whether there are folds. So unless you specifically give her a directive, wrinkle your forehead and then observe, you cannot actually comment on that in the still picture. In this still picture, of course, you see this is not the same as a real clinical If in real clinical, you are interacting with the patient and she do things like that, you can get them to do something. Here you can't. So that's a disadvantage. But to say, you can't say the facial folds in the forehead absent, because there are no facial folds even on the left side of this forehead. She's not wrinkling the forehead. So can you give
Right-sided eye is not completely closed, sir.
Absolutely, that's the observation. So, compared to the left eye, which seems very tightly shut, the eye closure of the right side seems to be, now this is without giving her a direction, seems to be partial. It seems as if she can't shut the eye tight on the right side, right? So you have already spotted that. You can then, of course, if this is a real exam, you can ask, sir, can I ask her to do something? And then you can ask her to wrinkle the forehead or whatever it is, and then demonstrate this further. So the answer is, even in this still picture, you can come to a conclusion from what you see straight away in the still picture, that this is probably a low motor neuron facial pulse. So then we will ask, okay, so that means what is the etiology? So what's your answer? What's your answer? Come on. You know the answer, don't you? Yeah. What term is that this well-known condition?
Bell's palsy.
Yeah, it's called Bell's palsy. That is a specific entity. The actual way it happens, we don't know exactly, but that is probably a Bell's palsy. So then they will ask, is there any other place you would like to examine? What would you say to that?
Ear examinations.
Yeah, ear examining. Because what is the other condition that can cause a Bell's palsy-like appearance, where there is pathology in the ear?
Ramsay syndrome.
The Ramsay syndrome is what is it? What do you find? What will you find in the ear? What will you find in the ear?
Vesicles on the back side of the ear.
Yeah. Not backside, it is inside. Not on the backside. Right? Vesicles in the inside of the ear. Bulia vesicles, because it's a piece of the that particular nerve. Yeah, right, okay. So you can say that. Now, of course, if this turned out to be upper motor neuron, say she was able to wrinkle the forehead quite well without any asymmetry, if it turned out to be upper motor neuron, which is very unlikely most of the time in the exam, but not impossible, then they will ask, what do you want to examine? What else would you like to examine? This is how the short cases go very quickly. What would you like to examine? Yeah?
Sensations?
Not sensations. What do you mean say?
Six.
Yeah, I mean, one answer is I would like to test the other cranial nerves, right? Okay. That is also an acceptable answer. But the best possible answer would be, if it turns out to be upper motor neuron, what would you like to examine? Yeah? Can someone say?
Eye movements?
No, those are other cranial nerves. Those are other cranial nerves. Right. So other cranial nerves is an acceptable answer, and they will allow you to do some other cranial nerves. Maybe you will find something. But in the rare event that this was an upper motor neuron facial palsy, what would be the associated much more? Yeah.
Reflexes?
Yeah, the motor system in the contralateral side, and in the opposite side, you would want to check the motor system in the left arm and the left leg, because that is likely to be affected if there is upper motor neuron lesion, hemiplegia. Are you following or not following?
Following.
Yeah, that's the way the clinical goes. Okay, so people who are smart and they follow up, Your meeting will end in 10 minutes. We rejoin with the same link, is it? We rejoin with the same link for what? At the end of 10 minutes? Can someone answer me? There is a note, this thing coming saying your meeting will end in 10 minutes. So do we rejoin with the same link or what?
Yes, sir.
Yeah, okay. Yeah. All right. So I don't want to stretch this more. Now, for example, even if it is lower motor neuron, and after the looking for the vesicles in the ear, you may be asked what other neurological examinations would you like to do? Then, of course, definitely the number one answer would be to check other cranial nerves, right? Okay, that would be the correct answer, and we will do it. But sometimes if they might ask what else, really, with this kind of thing, what is the other system that may be affected, especially with a serious underlying pathology? Or other part of the neurological system you would like to examine? Say, for example, you say you want to do other cranial nerves, and when you examine the eyes, you find there is some nystagmus. Then what do you want to examine? Yeah. Come on, yeah, a little bit slow now. So far, they're being good. I mean, if you find nystagmus in the eye, what else would you want to look for? One man in the neurological examination.
The cerebellar signs.
Cerebellar signs, of course. You would like to, because sometimes with the posterior fossa tumor, you can get involvement of the facial nerve. Where, and this bloody thing is coming. And you can have a facial palsy. And then so then they will watch you eliciting cerebellar signs, depending on the time available. Actually, most mediocre people will be stuck in the first half. They will hardly progress to this latter part that I'm talking about. But a really good student would have progressed quickly, and then if he or she has answered all this correctly and also quickly demonstrated your ability to do those things correctly, you can end up even with 9 out of 10 marks. So it depends. Okay, we'll go to the next. So this is certainly a condition that you. Now, if you are lucky, instead of telling look at the face, they may actually tell you a command like just check this girl's motor cranial nerves or something like that, Then you'll have to do all the motor cranial nerves, right? Okay. Now this one, now I told you these slides are real slides of patients I have accumulated over the last 50 years or so, from 19, actually there are some slides from 1971, no, 73, right? Now this is from Saudi Arabia. I was on call and my SR rang me saying that there is emergency cesarean section for a mother who has gone into labor, a mother with history of oligohydramnios who has gone into labor. And so that he and the SHOs were going into the theater already. So there even the consultants go out for difficulty. So I went. By the time I went, the baby was born, and this SR had assessed. He said the APGA was 0. The baby's APGA had been 0. Absolutely no reaction. Although it was it was not a death in utero or something. It was supposed to be a baby who had been live till that point. But when born, the APGA was 0, and he had immediately intubated the baby. So by the time I went, the baby was already intubated and they were ventilating. So I had to only check to make sure that the tube was in situ correct and all that. And so we continued with the resuscitation, doing all the things in the resuscitation, which I won't detail. But in spite of about 30 minutes, this baby never picked up. So this baby's APGA was 0 at birth, 0 at 5 minutes, and 0 at 10 minutes. Extremely unusual for that, okay? most babies would show some improvement with resuscitation. So in that sense, this is what you could call a fresh stillbirth. Fresh stillbirth. The baby had no signs of life and could not be resuscitated. Okay. So now this is the lateral view of the child's face and body. This is a postmortem picture, as you can see. What can you say? What is the classic appearance that this picture shows, which is compatible with the story? I'm
Potter's
audible to
faces.
everybody. Yeah. Go ahead.
Potter's faces.
Absolutely correct. This is called Potter's faces. Potter's faces is a sort of face that looks squashed from both sides. Squash means like pressed, right, from both sides. So you can get this sort of straight looking forehead and nose and fishy looking mouth. There is a little bit of low set ears, not here it is not absolutely all, but any of the Potter's faces is what I wanted you to focus on. So now this Potter's faces is the appearance of the face in such child. So that's a spot diagnosis. So this story actually exhibits what's called the Potter's sequence of exactly what had happened. So why was this baby having a flat zero APGA and was not resuscitated? What is the immediate cause of that? Can someone tell me? Yeah?
Renal impairment to the
No, that is not the immediate cause. That is the penultimate previous. What is the immediate cause why he could not be resuscitated?
Pulmonary hyperplasia.
Absolutely. Pulmonary, very good. Who is the person who answered? Pulmonary hypoplasia. This baby has completely, the lungs are collapsed and they are almost like fibros in the sense. And so even we gave massive inflation breaths and we ventilated with the maximum sort of tolerable pressure. In fact, most normal babies would have developed a pneumothorax with what we did. But this baby's lungs didn't expand at all because he was having pulmonary hypoplasia. So why was he having pulmonary hypoplasia? So this is called the Potter's sequence. So correct it with what you said before. Yeah. Because this child is having a severe renal abnormality. In fact, a non-functioning kidneys. So that's why that is why the mother had oligohydramnios. There was no urine being produced by the fetus, and therefore the fetus was getting squashed inside the mother's uterus, squashed, pressed. So as much as it presses the face, it presses the chest. So the pressure on the chest only causes the pulmonary hyperplasia. The lungs did not expand. So this whole thing is called the Potter's sequence. So, and we diagnosed this. So as much as we did a X-ray of this child, the lungs, and we did an ultrasound scan of the abdomen. And what we found was, normally what you get is a renal agenesis, but in this case, we got a very rare type of polycystic disease of the kidney with hardly any functional tissue. Hardly any functional tissue. This is in Saudi Arabia, they are very strongly consanguineous. So this is a strongly consanguineous marriage, not brother and sister, but very close. I think double cousins, like something like that. Okay. So there is a child who had severe polycystic disease and therefore renal failure right in utero and therefore leading to oligohydramnios, severe oligohydramnios leading to pulmonary hyperplasia and then causing this fresh stillbirth, right? Inability to be resuscitated at birth. Okay. It's not going on. All right. Okay. The third picture. There is a little bit of that's an artifact, like sort of white patches on the screen that's an artifact. But these an 8-month-old baby. It's a baby from Wales, where I was a consultant during my sabbatical leave. In 1981, 83. Now, this baby had come to the child welfare clinic, and the nurse noticed something and called the SHO in pediatrics, who of course later called the registrar and me. And so there was some reason for concern in this baby's appearance. Part of that is seen in this slide. So who can tell what is seen in this slide?
Bruises in the forehead and the lower chin areas.
Yeah. Well, actually, he has got multiple bruises. There is one there, and there is one here. There are few here and here also. He had on the other side, or he had here also. And on the chest and the legs also, he had this kind of bruises. So what is the feature of these bruises? What is the most important feature? That they are of different colors. Some are purple and some are red, some are brown, like that. So what does that suggest? This baby has got multiple bruises, very large bruises on the face and the body. They are of different shapes and different colors. And also they are sort of spread all over. What does that suggest?
It suggests physical abuse.
Yeah, it suggests physical abuse. Because that's a typical feature. No? One is the bruises are not, yeah, my gosh, not compatible with one injury. It is not compatible with any story. Mother can't say he fell off the bed and all that, in which case he won't get bruises all over the body. Second thing is they are different times. Have not happened at the same time. So that also is against. So it is strongly suggestive of what is called non-accidental injury or physical abuse. So actually in this child's case, we confirm that by just a single investigation. Unfortunately, I can't find that particular film. What do you think the investigation did which clinched the diagnosis? Anybody? Anybody? The baby of 8 months. Yeah, we did a skeletal survey of the whole body, including the limbs. And what we found were multiple green stick fractures at different stages of healing. So the same kind of patterns of tissue injury we saw in the bones also. Different injuries at different stages of healing. I mean, none of them were serious injuries, but there were like many small fractures like this. So we could clinch the diagnosis of non-accidental injury or child abuse. Now, this is from that I told you I was given a set of slides by Save the Children Fund. They are from all over the world. But it shows a condition which I was very much familiar with, especially during the time I was a registrar in the 1971 or 72. Can you tell me this? Both one is a newborn, other one is a school child. Both are having the same condition, and both are showing the same physical sign, which has a descriptive term. Actually, it is in Latin, the descriptive term is in Latin. Who can tell what is the condition and what is this descriptive term? Actually, the newborn displays it in the correct way. Actually, in the older child, it's a bit difficult to, it doesn't fit with that so-called description, but still you all should know. From what I said, you should know. Anyone? Anyone can guess what the condition is? Okay, I'm going to tell you. So this is the physical sign called Risus sardonicus. R-I-S-U-S, Risus sardonicus. By the way, if you all want to benefit from these slides, you should take down the appearance and the diagnosis and then go and do quickly your own search, right? And you may get sometimes better pictures of the condition on when you search, and then it will remain in your mind. So this is called Risus sardonicus, or the sardonic grin, means a sort of sarcastic sort of looking grin, like this thing. You can see that on the newborn baby's face. On the older child, of course, it looks more like a grimace than a grin, but this is supposed to be the sardonic grin. The main features of sardonic grin, like in that other child with the nasolabial field, there is a spasm of the periauricular muscles, right? And that causes this appearance, like a little bit of like as if the child is grinning, right? And with the mouth closed, the grin. So this is a sign of this is tetanus. As you know, trismus or inability to open the jaw is the main presenting physical sign for most people. That's why it's also called lockjaw, Lockjaw, lockjaw. This is tetanus, and both these children have the classical sign of Risus sardonicus. And if they were live and you try to get them to open the mouth, they wouldn't have been able to open the mouth due to trismus. Okay. Now, my slides are not in any order of importance or any order of this thing. They are sort of from here and there, because the only purpose is to show you rare physical signs which you are unlikely to have seen in your practice up to now. Some of you may have seen, but others may. Now, this is you see, in the short cases which are used very much, especially in postgraduate exams like the DCH and the MD, we give a candidate a large number of short cases, not 2 or 5 or 6. And there are clearly 2 types in the short cases. That is, one is where we actually get you to examine a system or a part of a system and check the techniques. The other is more like a spot diagnosis. We just ask you to observe a particular part of the body or the anatomy or any part, and then you are supposed to spot some abnormality straight away. So that they are called spots. So usually in postgraduate cases, there is a mixture of about, say, if there are 3 examinations, 3 spots like. Now in the short cases, we don't actually give spots as such. But sometimes we have like a mini short case, which is a spot, like the facial palsy, which I showed you earlier. I mean, facial palsy is not a spot because we are getting you to do other things later on in the short case. Now, this is really almost a pure spot. So all we are telling is look at this child's face and pick out the most significant abnormality that you can see. So who can answer that?
Enlarged cornea in the left eye.
Yeah, absolutely. Very good. I mean, this is called megalocornea. A very large cornea. You can see, you can't see the white of the eye above or below the cornea, right? In addition, you get a vague impression of what else here. It's not very difficult. In that eye, what else do you notice? Okay, I think what you are supposed to notice is called circumcorneal injection. Injection means like it's a suffusion, no. Capillaries around the cornea. It's not like in a conjunctivitis when the whole of the white of the eye is red. In Kawasaki's and all non-purulent conjunctivitis, the whole of the conjunctiva is red. Here you get circumcorneal injection. You get just redness just around the cornea. So this is a classical picture in acute close angle glaucoma. This child has presented with severe eye pain and he has got acute close angle glaucoma. Close angle, I don't know, I forget now. Right, okay, glaucoma anyhow. Large cornea and the circumcorneal injections. That's all that is seen in this slide. So it's the ability for you to focus and identify the abnormality. Okay, this is a slide from Saudi Arabia. I mean, it's supposed to be sideways. I put it upwards. Now, again, this is a old slide, I mean, from 1990 or 91, like. This is a baby that was my postnatal ward HO was asked to see this baby because he was supposed to be jittery. So the nurse said, the baby is jittery. That is some kind of tremulousness. The baby had been born the night before, right? So what do you see in this baby and what do you think? How do you connect up the symptom and what do you see to a diagnosis? Now, this is a common condition, but you don't see this now because this condition is very much better managed now compared to those days, which is nearly 30 years ago. Who can tell? Why do you think this baby was jittery? In fact, what is the first thing you should have done when you saw this baby? And especially when the complaint was jitteriness. Can someone answer?
So is it macrosomia due to gestational diabetic?
Yeah, correct. Have you all seen this set of slides before or you're betting on your own? Have you seen or seen from your own seniors or not? I mean, it doesn't matter if you're seen. If you're getting that on your own, that is really, really good, Okay, yeah, your answer is quite right. This is called a classically macrosomic baby. Macrosomic is just large. Every part of the baby is large, especially the face and the head, right? So why was the baby jittery? Why was the baby jittery? Yeah. The person who answered, can you tell me? I mean, you said it's the baby of a
Hyperglycemia?
Can be.
Yeah, hypoglycemia, of course, hypoglycemia. You said baby of a diabetic mother, right? So this is, of course, you have to put another adjective. It's a poorly treated diabetic mother. I mean, poorly managed during pregnancy. If the mother was properly managed, you won't get this. These are all features of insulin resistant hypertension, in a poorly managed diabetic mother. So this is a classical picture of a baby of a diabetic mother, poorly treated. Large baby called macrosomic. They get hypoglycemia and they are very plethoric. Actually, the plethora is not clearly seen. They are like a beetroot. I think this child's PCV was something like close to 60, right? I think we have to do a plasma exchange or something like that. So very plethoric babies and they become hypoglycemic. So there are quite a set of abnormalities they can have, including cardiac abnormalities, spinal abnormalities, etc., which you can see. This child, as far as I remember, did not have any major abnormality. He was just macrosomic and plethoric and jittery. So this is the baby of a diabetic mother. Okay, these from the teaching aids at low cost slides. It's the right slide is a close-up of the same baby on the left. All right, so this slide is supposed to show mainly one physical sign which most of you miss in the actual exam. Of course, in the exam, it's not as marked as it is in this child. It's a lesser degree. But because of your superficial approach to examination, you all missed this. And therefore, ultimately, you probably end up failing the short case. What is the physical sign that is obvious in this child?
Central cyanosis.
Absolutely. This is severe central cyanosis. You can see the lips and the tongue. I mean, the baby has got oral thrush, okay? So that is the blotting in there that you can see a little bit of flaky stuff on the tongue. But this baby has got central cyanosis. So the moment you have a suspicion, if you are in doubt, what is it that you must look for? What is it that you must look for? I mean, you must look for peripheral cyanosis also, which is there. You can have peripheral cyanosis without central cyanosis, but you can't have central cyanosis without peripheral cyanosis. There will be some cyanosis in the nails and toes also. So you must look for what else? What is the clinching point to say that this is cyanosis?
We can check for clubbing.
Absolutely. Which is what you all don't do, or even if you do it in a utterly incorrect way. So the early degrees of clubbing you totally miss. So this time was in the exam, we gave quite a few cyanotic cards with like the murmur itself is not very tough in these cyanotic cards because they are usually a VSD or a pulmonary stenosis murmur that you can pick up. But if you miss the cyanosis and the clubbing, you totally miss the diagnosis. And then you imagine them all. So this child has got central cyanosis, and here we have not shown the fingers, he's got clubbing. And from the right side picture, what can you say about this child? What is the condition he has got? From the facial appearance on the right, what is the condition this
Down
child has?
syndrome?
He's
Down
got Down syndrome. Actually, I think we gave about 2 or 3 patients like this combination to the exam. Some people totally miss the Downs because we don't tell it is Down. We tell examine the cardiovascular system. So not only did they miss the Downs features, they miss the central cyanosis, they miss the clubbing. So obviously you are going to fail badly in your short case. Right? So you have to be thorough, right? You have to look at the face in a cardiovascular examination, facial appearance for dysmorphism, all that. Looking carefully for cyanosis, looking carefully for finger clubbing. You can't do it from above. You have to bring the finger to your eye level virtually to detect early degrees of clubbing, right? So these are important, right? So this is a Down syndrome baby who has a complex cyanotic heart. I mean, he has got some infection and been treated with IV antibiotics, I think. He has got thrush in his mouth. Okay, this is a very straightforward diagnosis. No, this condition is not common nowadays. If it is there, we will give it for a spot. What does this child have? I have a lot of signs.
Angulostomatitis?
Yeah, angular stomatitis. Absolutely. You can see the angles of the mouth. They're not clean looking or sharp looking. Should be very fraying sort of this thing. This angular stomatitis. So that can be associated with anemia. It can be associated with glossitis. It can be associated with chelosis or dry cracking lips. Actually, this baby doesn't have any of these. He has only got angular stomatitis. So this is a real riboflavin deficiency. But you can get angular stomatitis in other conditions, sometimes in iron deficiency even. You can get mild degrees of angular stomatitis. Right, okay. This we will skip. This also, I think I'm going to skip because, yeah, we'll stick to this one. Actually, this baby also, you're supposed to notice what's called the abnormal tongue, protruding tongue, which is supposed to be large, but it's not obvious in this child. So I'll come to this child, where hybenate is absolutely obvious. And this is what's the sign called? Macroglossia. Severe macroglossia. So this, of course, I mean, this is a rare syndrome called Becker-Wiedemann syndrome. Again, this may be presented with jitteriness because they get hypoglycemia. This is in the neonatal period. And he was dysmorphic, and it was a Becker-Wiedemann syndrome. And the feature that you should have spotted straight away is the macroglossia, which is very obvious. Of course, you can get macroglossia. I mean, you can get it in untreated hypothyroidism or cretinism. Now, the previous child, but he's not getting there. This child, of course, I'll just tell the history. He is actual patient of mine. This child had a condition called Pompey's disease, which is a glycogen storage disease, mainly affecting the cardiac muscle. And they go into heart failure in mid-infancy. This child's mother was a school teacher, and this child came with dyspnea in infancy and had heart failure. And he had the fear. I mean, it's a child of a consanguineous marriage, and he had heart failure and with macroglossia. So let's quickly go on. This is a very rare condition, but the story is interesting, so I will tell it. Now, this baby came to me when I was a consultant in the Armed Forces Hospital in Saudi Arabia. This is the only daughter. She was about 2 years old, I think, of a major in the Saudi army. And the wife was, I mean, we don't see their faces, but she was a very sort of cultured English-speaking lady. And what she told us was that this baby has been unable to swallow anything for the last 1 week. And that she regurgitates all the milk that is given. And that she has got a cough. That was the only thing she told. And she told it sort of happened spontaneously. And it became progressively worse. So to be honest, we were quite clueless as to what was going on. But we saw that what she said was true, and that the milk and all was in the mouth, like there was always sort of, if you want, when you try to feed her, it looked as if she had dysphagia. The fluid was not going down. And because there was a rattle in the throat and she was coughing like nothing, we did a chest X-ray. And that is how we made the diagnosis. When we did the chest X-ray, we had really good radiologists there. The radiologist noticed something in addition to changes of bronchopneumonia. Right? What do you think? And then when we questioned this lady, she admitted that this child had been admitted for a pneumonia about 3 months before, and that she had gone to the civilian hospital. You know, there is a civilian hospital also close by, and really speaking, civilian hospital has much less facilities than the Armed Forces Hospital. And for the child of Armed Forces officer to have gone to civilian hospital itself made us very curious why she went to the civilian hospital. Right. But anyhow, our curiosity was very much answered by the radiologist. Unfortunately, again, I don't have the actual X-ray of this child's chest. So, having listened to all this story, I have told this story, of course, in various lectures and also, I don't know whether you want to come to here. What do you think this condition is? Anybody has some knowledge? Okay. What we are
The
seeing,
mother had used caustic substances and fed the baby.
yeah. So do you know about this patient or heard about it from anywhere before? You are telling on your own.
Sir mentioned it earlier in the child abuse lecture.
Ah, that's it. I remembered, yeah. Absolutely correct. I didn't show you this slide, neither. I just told you the story, no? Did I in the child abuse lecture, did I show you this slide? No, I don't think
Yes,
so.
sir.
I
In
did show.
negligence.
Huh?
Yes. Yes,
Ah,
sir.
very good for you to arrange. Yeah. So this is what's called von Munchausen syndrome by proxy, where the mother creates the symptoms or the illness deliberately and presents as if it's a natural infection. In Munchausen syndrome, the patient himself does it. Very often it's soldiers and people who are trying to evade going to the front and all that. But here it is the mother, I mean, who was a psychopathic person who created this story, because and the clue was we saw multiple rib fractures on that pneumonia, the bronchopneumonia X-ray. Some of them were healing, and because at the time she went with the pneumonia 3 months ago, most of those fractures would have been fresh fractures. So and they don't have a radiologist even there. So only the pediatrician has seen the X-ray, and pediatrician had totally missed the fact that there were some rib fractures and only noticed that there was a bronchopneumonia. So we noticed that there are old rib fractures and a bronchopneumonia. So then only we made the diagnosis. So this is a case of chemical abuse. It's not physical in the sense the trauma is chemical. She has put caustic soda, sodium hydroxide crystals, which are commonly available there as a drain cleaning thing. She has put it into the baby's milk. So the baby, by the time we realized the baby was already severely damaged, in the sense baby had severe narrowing of the esophagus, like the burning of the esophagus. Actually, I think even now, if the baby is living, I don't know whether this baby is living yet. If he's living, she must be getting regular esophageal dilatations, because there was narrowing of her esophagus due to this caustic burning. And it was causing this aspiration pneumonia. And later, with the forensic people, there are no JMOs in Saudi Arabia, but people who are knowledgeable about forensic medicine said this is the classical appearance of caustic burns around the mouth. You can see the stuff drooping on either side and causing burns on either side. So these are completely classical appearance of that. It's very unlikely that you will get short cases like this. Okay. Okay, this is again from the teaching aids at low cost slide. So if you all have heard these stories, which I may have repeated, I use these stories and anecdotes in different instances in my teaching. Don't hesitate to source though. But if you have got it on your own without any clue, I mean, I will have to take your word for it. That is also very creditable. But if you already have prior knowledge, tell me that you had prior knowledge. Now, my God, this will end again in another 10 minutes. So we will only do it one more time, okay? Now, this is a very, very common condition during our time. It's the same child in both pictures. The picture on the right shows a pathognomonic physical sign. So can someone tell me what the diagnosis and what the pathognomonic physical sign is? Yeah? Come on. Come on. Come on, man. This is an easy one. Yeah?
Dental caries.
No, yeah, well, yeah, there is an appearance that the child has got some kind of deformed teeth in the upper jaw. I concede that. Difficult to say whether they are caries or not, but that is not the. I'm using the word pathognomonic physical sign. There are only very few pathognomonic physical signs I have told you in pediatrics left now. So these are, and I told you these are condition which is actually recently we have had a relapse of this condition. but it was virtually eradicated before that. What is the condition? Well, this is classical appearance of measles, Ben. And the physical sign is Koplik spots. We'll start with the Koplik spots. In the inner cheek, in the bulbar mucosa, you can see especially here. These are Koplik spots. They are white spots with the halo of redness around them. Right? So those are Koplik spots. They occur on the third day of measles. And this is the next day when the rash has just appeared. It's erythematous maculopapular rash. And you get a conjunctival suffusion. And you get a runny nose, cough. And of course, this child is very ill, high fever and cough. So this is a classical picture of measles showing Koplik spots in the buccal mucosa on the third day. Right? Okay. So this is measles and Koplik spots. I think due to lack of time, I will skip this. This also I will skip. This also I will skip. This also I will skip. These are. So, yeah. This one we'll stick to. Okay. Who can now, like that child with glaucoma, who can focus on this face and try to find some abnormality and then try to link it up and tell what the condition is. So these are white child. These again from Wales, from Newport in Gwent, Wales. Who can see an abnormality? Okay, I'll point it out. Look at both eyes. You get like a ring. Actually, it's not a continuous ring. These are really spots. They are white spots, but they are very close to each other. That's why you get almost a ring-like appearance in the iris. These are called brushfield spots. They are like the Koplik spots for measles. These are pathognomonic for Down syndrome in white children, children who don't have much melanin in their skin or the iris. You don't see it in our children with Downs. In white children, you get these brushfield spots. And you can see this is classic hyperteliorism. The eyes are very far apart and there is a depressed nasal bridge. There is a small pouting mouth. The ears are slightly low set. You're supposed to have more than 1/3 above the line from the outer canthus. So this is a child with Down syndrome. Child with Down syndrome. I mean, he had other signs like clinodactyly and palmar-creases and all that, and showing brushfield spots. Okay. All right. Let's go to the next one. I think I'm going to skip. This is the same child with glaucoma because, okay, I'll stick to this, although this is from teaching aids at low cost. I will stick to the commoner things that you are likely to get in your short cases without, I'm skipping some of the rare things, which of course I used to show the final year students during final year teaching. But now today I will, now this child has got something in the head. This is a Sudanese child actually. This is from teaching aids at low cost, which is a condition that you can get for short cases even today. But this particular physical sign, you are very unlikely to see. Who can say what it is? It's in the head. Anyone? Okay. This is described as the hot cross bun appearance. That's a descriptive term. But it is due to both parietal and frontal bossing. So all the four, the frontal, and what happens is the bossing is marked on each side, and what you get is like 4 bumps in the 4 corners, although it's not so clearly seen, especially because the head is not shaven. You get as if 4 bumps. That is why it is called a hot cross bun. Now that's a kind of bun that is popular in England, where you get a cross of cream like in the center. So you get 4 bulges instead of 1 bulge in the bun. It's called a hot cross bun. So this is called the hot cross bun appearance because there is bilateral frontal and parietal bossing. So what this baby has is, what this child has is rickets. So when you see this, you should go down and look for rickety rosary, look at the hands and legs and things like that. So these are very common case that we give children with rickets. And many people are not sure how to examine. They don't pick up all the physical signs. So you go and learn about those. So this is the hot cross bun appearance in a child with rickets. I mean, some of these are what are called rare, but then this is a child with what's called anophthalmos, bilateral anophthalmos, complete absence of the eye at birth. These are extremely rare condition. It is also an embryologically a neuroectodermal plate malfunction like spina bifida. So it is associated with spina bifida, myelomeningocele, myelocele, and encephaly. All of these are in one group. So one thing that is worth knowing about these conditions is all of them are preventable by taking preconceptual folic acid. So if a child has anything like that, at least for the next pregnancy, the mother should be on high dose folic acid, 5 milligrams. Normal people are supposed to take 0.5 milligrams preconception. So anyone who gets married and is having unprotected sex and is expecting a baby should be on 0.5 milligrams of folic acid, because that will prevent all these serious neuroectodermal defects like spina bifida, myelomeningocele, meningocele, encephalocele, and encephaly or anophthalmos. This is that same child. This is that same child. This is a child with measles again. You can see the rash even behind the ear. That's where it starts normally. You can see the conjunctival suffusion. Okay, I mean, these are rare conditions. So I'll show you the common ones. These are not an uncommon condition. This is an infant. What do you think he has got? You must, in skin appointment, you should have learned how to describe rashes. So what do you see in this rash? What do you think this condition is? Can anyone guess? This is chicken pox. This is a baby with severe chicken pox. Now, this is the sort of late stage where it has started crusting. But if you look carefully, you can still see some vesicles. Now, that's a vesicle. That's a water film. Because in chicken pox, you can get vesicles, then you can get pustules, then you can get crusted lesions. As the child becomes older, you get more crusted lesions. And this one is actually a severe form of a chicken pox because it is a hemorrhagic chicken pox. There is actually a little bit of okay, we'll come to this one. Can you all see?
Yes, sir.
So only 22 have joined so far. Wait and see it. Okay, till the others join. So what can you see in the, this is a boy from Saudi Arabia. According to his father, he has got this swelling gradually over the last 4 to 5 months. It's not painful. What can you see? Okay, these more surgical short case than a pediatric short case, to be honest, right? Okay. So these, I mean, you can see a lump involving the whole of the right side of the face, right? So the moment you see a lump like this, the first thing you have to find out is it confined to the cheek or is it involving the mandible and the postmandibular areas? So first thing you must do is to look for the mandibular notch, which you can't see. So you can see that this is really a more likely to be a parotid kind of swelling rather than a swelling from the cheek. Because if it is mumps, you should be able to see this. And of course, this is non-tender and it was rock hard, this swelling. And if you look carefully, you can see some abnormality here. On the same side of the tumor, you can see the gum is really fleshy. There is hypertrophy of the gum. So, and these are sort of rock hard tumor, non-tender, insidious onset, involving the mandible notch cannot be felt, so involving the parotid also in a child from Saudi Arabia. What do you think this diagnosis? A rare condition, especially in Sri Lanka, it's quite rare. Anybody has heard of this? Yeah, these are Burkitt's lymphoma. Burkitt's lymphoma. Go and read about it. Burkitt's lymphoma. It's a kind of lymphoma. It can be treated like any other lymphomas, but starts usually in the jaw area. Burkitt's lymphoma. Now, if we saw a red lump like this and it was tender and it was during my time, the first thing you would have thought of was mumps. Especially if we think it's a parotid swelling, we will think of mumps. So then what we'll do is we will get them to open the mouth. Mumps can be unilateral or bilateral. Generally, it becomes bilateral later, but at the beginning, it can be unilateral. When you open the mouth, you can see in the buccal mucosa, like the Koplik spots, there is a spot where the Stenson's duct or the parotid duct opens. So if it is mumps, that is seen very clearly because it is inflamed and stands out like a puncture with red area. So that confirms the diagnosis of mumps, right? Okay. So, but of course, mumps is quite rare now, and if there was even, we will not give it for a short case because it will be. Okay, this child. Now, these from teaching aids at low cost. So this is a child who had actually come to a field hospital in sub-Saharan Africa. What is the physical sign, the striking physical sign that this slide shows? Anyone? Anyone? Come on, man. No one? Look at it carefully, the face, and try to. I mean, these are deeply sunken eyes. I mean, can't you see the eyes are like in a pit? These are deeply sunken eyes. And from the general appearance of the child, you can see the child seems to be like semi-conscious. From the picture, you can see it's like this. So this is severe dehydration. With this child has hypovolemic shock, right? And probably this is a child with kwashiorkor. That part is not seen in the slide. But the slide is to show deeply sunken eyes in severe dehydration. I think if I have time, okay, we'll stick to the common one session there. Now, this, of course, you can definitely see, get in the short cases we give you. This kind of patient, normally what we do is when we have a patient like this, we tell you, do a general examination first, and based on what you have seen, you select one or more systems to examine. And then we ask you to present. So this one will fit into that very easily. What do you see in this child? Those are his teeth, by the way. Yeah. Somebody say something. Yeah, tell it now.
Thalassemia facing.
Thalassemic phase, you said correct. Okay, that is correct. This is the phase of a badly managed chronic hemolytic anemia. It doesn't have to be thalassemia. Actually, this may be at sickle cell anemia. Badly managed chronic hemolytic anemia, where the extra, the hemopoiesis is going on in bones where it is not supposed to be going on, like in the cheek bones and places like that. So you get a severe maxillary prominence, and then this, see, malocclusion. Can you see the teeth are well in severe malocclusion, and it looks almost like we call it a mongoloid face. We don't use the term Mongol now because it is derogatory, but it looks like very superficially when you look, it looks as if it's like a Down syndrome, but it's not a Down syndrome. It's due to this extra medullary hemopoiesis in different places, and you get this prominent cheeks, malocclusion, and depressed eyes, so what's called the thalassemic phases. So this happens in chronic thalassemia. And of course, if you are lucky, there might be a tinge of icterus there. And if you are lucky, there might be, if he is a pre-transfusion thalassemic that is given, you might find pallor there. So you might find mild pallor, mild icterus, and you get these abnormal phases. Then when we ask what is the system you want to examine, you say obviously the abdomen, because he will have both hepatosplenomegaly, like that. So these are sort of something that you can get in your short cases. I will skip right. I will go to the more interesting ones only, because there is so maybe this is a real child, my patient from 1973 or maybe even 71 when I was registered Professor Piani Suisa. I remember this boy still. He was brought by the grandmother. He is from a fisher village in Katana. But he was brought all the way to the Lady Ridgeway. What is the striking physical sign in this boy? And what do you think this will be? This boy was nearly 11 or 12 years old. He displayed so many physical signs. Actually, it was like a museum of physical signs. This guy. Who can just look in the context? I'm telling you, this is from the early 1970s. He is a big boy, 11 or 12-year-old boy from a fisher village in Katana, brought all the way to the Lady Ridgeway. I don't know how they afforded it, but anyhow. And if you don't give the answer, I will just give one physical sign that the grandmother mentioned. Not physical sign, one symptom. Without the symptom, you can't tell, is it?
Pallor? Pallor, sir?
Pallor. Absolutely. Who is the girl who said pallor? Yeah, who is the one who said pallor? Very good. This child is severely pale, like a bed sheet. He's got a little bit of angular stomatitis because severe pallor is what we saw. And the grandmother's physical sign was pica. She said, "Me had a pandu." You see, mandama is for severe malnutrition like marasmus and all. Pandu is when children become very pale. And in the villages, they call it pandu because they start eating raw rice and they eat the charcoal. They used to brush teeth with charcoal. So they used to eat the charcoal and things like that. Then they say muta panduva. Like that panduva means actually severe anemia. So these are child with severe hookworm anemia because he's from a fisher village in Katana where they defecate in the beach and they don't wear slippers and the sand is steaming with hookworm larvae. So he had classical, we examined his feet and he had this typical, in Singalinga, it's called ground itch. It's called ground itch actually because it is quite itchy, but it's very, you get punctums, you get several punctums like holes like in the foot. So this child's sole was riddled with ground itch. Right, he is a severe hookworm anemia. Severe anemia, he has severe pallor. He has angular stomatitis, and he had the symptom of this pandu or eating things which are not food. That's called pica, P-I-C-A. Pica is it's a Latin word, pica, perversion of appetite. So this child, why I said plethora, he had severe cardiovascular system signs. Because when you have severe anemia, you get a hyperkinetic circulation or hyperdynamic circulation. So he had severe tachycardia and he had what's called a classical water hammer pulse or a collapsing pulse. I hope you all know how to elicit a collapsing pulse. Then he had a hemic murmur at the base of the heart, normally in the aortic area, which is a short systolic murmur. He also had a continuous murmur somewhere here called the jugular venous hum, right? And he had tachycardia, of course, and hyperkinetic circulation. Of course, they can even go into heart failure, but this boy was not in heart failure, but he had ankle edema for a different reason. Because hookworm, not only does it suck the blood, it also causes a severe loss of protein into the gut. So actually, it's a cause of protein losing enteropathy. So the child is hypoalbuminemic. So he had ankle edema, this boy. Okay, anyhow, yeah. So these, you won't see such severe hookworm anemias now, but it's worth knowing about because there are still, I don't know if our country will regress to that level, but I hope not. But in the era where we heard hookworm, we used to see a lot of children like this with severe anemia and all the signs of severe anemia. Now, this is very quickly, I think, because the time is going to, this is herpes labialis or what are called cold sores, vesicles on the lip, usually due to herpes simplex. They normally occur by itself. It's not normally associated with herpes encephalitis, although you can have a history of herpes labialis prior to the encephalitis. But this can be associated with other febrile. This girl actually had a pneumococcal pneumonia, but she had cold sores simultaneously. Okay, if this is going to be the last one, let this be the last one. Now I'll tell you this story. This girl was being followed up in my, actually we had a seizure disorder clinic in Saudi Arabia, and this girl was a child with intractable seizures. And she came with status epilepticus about 2 days prior to this picture. And we had to give her intravenous phenytoin to control the status epilepticus. And just about 36 hours later, she's developed this condition. So what is this condition? Who can give the diagnosis?
Is it Stevens-Johnson syndrome?
No, it's not. I will show you a Stevens-Johnson. Stevens-Johnson syndrome is the most extreme form of erythema multiforme, where there is involvement of the mucous membranes of the eyes. And what you get is ulcers like in the mucous membranes, in addition to a erythema multiforme kind of rash all over the body, which sometimes can have bully, but commonly doesn't have much bully. So that is Stevens-Johnson. So I'll show that Stevens-Johnson in another child. I think I have it here. This is something else. This is also a severe drug reaction, but not Stevens-Johnson. Look at this lesion. What does it remind you of? What has happened here? The epidermis has peeled off. This is like a scald. So this is called scalded skin syndrome, SSS. Scalded skin syndrome occurs due to two things. Well, the serious one is due to drug. Then it is called toxic epidermal necrolysis, TEN, toxic epidermal necrolysis. That is, yeah, can you see this all like scalds? The skin is just peeling off. Skin is peeling off. You don't get that in Stevens-Johnson syndrome, right? See, yeah, scalded skin syndrome, toxic. You can also get scalded skin syndrome due to a staphylococcal infection of the skin. That is quite uncommon, but you can get scalded skin syndrome due to a staphylococcal infection of the skin, right? You can get bullous impetigo, you can get scalded skin syndrome. But this is scalded skin syndrome due to toxic epidermal necrolysis. This was due to phenytoin. Okay. As there's time, so I'm giving you common ones, things that you can get. Now, sometimes we don't, we just tell you this baby has come for the 6-week follow-up at the clinic. Or we say this is a newborn baby, do a newborn examination. Or we might ask you to do a developmental assessment in a normal looking child. So now if this was a postnatal visit at 6 weeks, so this was actually a postnatal visit at 6 weeks, this baby. The only complaint the mother had was, she said, there was a tinge of icterus. But there was no history of any reasons. We didn't know what the blood group was. But the reason for this was obvious when you examine this. Can someone from the appearance of this head tell what do you think the reason was? Anyone? What do you think?
Is that a capsular hematoma?
Hematoma. I think there is one girl, I don't know her name, who's quite good, giving very. You haven't seen these slides before, have you? Through any other friend or anything like that?
No, sir.
Good. If you have not seen, it is very good. Because sometimes, these slides I have given to some of your senior batches and all that, so you maybe have seen it. Anyhow, this is a baby with a cephalematoma, left parietal cephalematoma. When you feel the head, you can see a big lump here, absolutely confined to the suture lines. That's the main diagnostic point. Doesn't come into the frontal area, doesn't go beyond to the other side. It's confined to the suture lines. In the initial phase, it is totally cystic in the sense you can press, it's like a cyst, you can press. But when it is late, it's not totally cystic because the blood has got organized here. It has got solidified and you actually feel it as if there's a crater. This area is very hard and in the center it is soft, as if there's a crater, right? And it's non-tender. So these are organized cephalematoma, which will totally disappear if you leave it. You don't have to do anything for it. And that can, of course, a large amount of blood has been lost. So you can get a little bit of hemolysis going on even by the time of 6 weeks. That's why it causes a little bit of tinge of icterus. So these are baby with cephalematoma. Yeah, these are another common. Now, I told you, sometimes we give, like, say, and you might just find some finding. So, like, this baby also only had this particular thing. Otherwise, it was a normal baby. What is this condition called? You can tell me.
Hemangiomas.
Yeah.
Hemangiomas.
Yeah, it's a capillary hemangioma, also called a strawberry nevus, because it looks and feels like the skin of a strawberry. It's not just smooth. It's not smooth. By the way, this is not a port wine stain. Port wine stain you get in a condition called Sturge-Weber syndrome, and that is very flat. It's not elevated and it's not irregular, and it's sort of like a more purplish kind of stain, right? Sturge-Weber, port wine stain. This is not a port wine stain. This is a capillary hemangioma. Very common condition, skin condition in see, And generally they tend to be multiple. If you find one lesion, if you examine the whole body, you might find one or two others here and there. Totally benign condition, and the natural history is it regresses spontaneously in 95% of the cases. In 95% of the cases, this will totally disappear by the time the child is about 1.5 years or so. So the management is total reassurance, unless it interferes with function. For example, it can overhang the eye and impair the vision, or it can be in the nose and interfere with breathing. Now, then you have to do something, but actually it's messy doing anything. Best thing is not to do anything. It's a capillary hemangioma or a strawberry nevus. Natural histories, it will regress on its own within a period of about 1 to 1.5 years. Right? Okay. So you can get these in your short cases. What is this one? I don't think you will get this, but this is not the condition that you may not. You can see this condition even now. What has this baby got? Come on, man. Have a look at what is there. Some of these are more surgical short cases, okay, not pediatric. This is classical periorbital cellulitis. Can you see the eyelid is red and shiny, tender and painful? This is a very dangerous condition because you get the angular veins here, which links with the cavernous sinus. So if this is not quickly treated, it can lead to cavernous sinus thrombosis. I've seen it when I was a registrar in the Ridgeway. It's a life-threatening condition. So these normally due to Staphylococcus aureus. We have to treat them with intravenous flucloxacillin, and we used to give both ampicillin and flucloxacillin. So the periorbital cellulitis. These are common condition. These from Saudi, but you get this condition in Sri Lanka now. Who can make the diagnosis?
Cutaneous leishmaniasis?
Cutaneous leishmaniasis, absolutely. You get an indurated ulcer with a raised edge and with crusting. It's red, round, and it is very sort of hard at the edge, raised edge. This is classical appearance of cutaneous leishmaniasis. So we get cutaneous leishmaniasis in Sri Lanka, but we still don't have, I mean, we have been 1 or 2 rare cases of visceral leishmaniasis, which is also called thalassia, but this is now well described. So you must know about this. This is a very common condition which you might come across. What is this? Come on, men. What is this? What face is? Come on.
Cushingoid faces.
Yeah, these are cushingoid faces. This is from Saudi actually. This fellow is about 11 years old and he has got steroid-dependent nephrotic syndrome. He has had about 10 courses of steroids. So he's cushingoid. He's got a moon face. He has got hypertrichosis, excessive hair on the forehead and on. He's got this lush cheeks. He's got a little bit of acne, not obvious. Like that, of course, he's very short for his age and he's obese. Right? So this is cushingoid faces. You wanted Steven Johnson? This is Steven Johnson. Can you see it's quite different, the appearance to toxic epidermal necrolysis. You get vesicular and bullous lesions with hemorrhagic bullous lesions. But you don't get scalded skin. But the most affected areas are the mucous membranes, the mucocutaneous junctions. So this condition, they can get blindness. Lips are affected. In girls, vaginal orifice, urethral orifice, anal orifice, even anywhere, periorificial rash. So this is Steven Johnson syndrome. I think so. We have not finished. So I think I'll quickly go back in the slides and show you the rare ones which I didn't show you. So I'll just tell you the diagnosis in the ones that I skipped, okay? This I can't remember. This is Pompey's disease. With Beckwith-Wiedemann with hypoglycemia, macroglosia. This is Munchausen syndrome, chemical poisoning. This is a rare slide. This child has got, can you see, webbing of the neck? This is a boy with webbing of the neck. So it's not Turner's. I think he's a Noonan's, but he also had a very large head with a wide anterior fontanelle. OFC was very large. And you can see he has got deformed low set ears, the part of the syndrome. What is seen in this slide is we are trying to trans-illuminate his skull. Somebody is actually pressing a torch from the other side and looking at, you can see a sort of pinkish hue here. So there is some kind. So he had, we did a CT or MRI, he has holoprosencephaly. He's got a fluid-filled skull, you know, on top of the brain. So this is, I mean, these are rare conditions, you don't need to know. This I will skip. This is actually from teaching, this is again severe sunken eyes, both dehydrated children, severely dehydrated children with sunken eyes. This is Horner's syndrome. Go and look it up. I think you learned it. He has got dilated pupils and there is ptosis. Ptosis with dilated pupils. What you see here, these are called freckles. They are not. This is a very rare thing, you know. This is called the Cyclops deformity. Again, this child has got holo. I mean, he was alive at birth, but lasted about 1 or 2 hours. Cyclops baby. These are just curious. These again a rare condition. That's why I didn't show you. It's called, well, the abnormality is here. You can see a ridge of tissue extending across the cornea into the, across the conjunctiva into the cornea. This is called flictenular conjunctivitis. If you all want, you can take it down and go and read it up. Flicten, Phlycten, flictenular conjunctivitis. It's a non-specific reaction to certain infections like TB. It can be due to other infections like TB. Now, erythema nodosum is also something like that, a non-specific reaction to certain inflammatory conditions or infections. This is flictenular conjunctivitis. This is just to show tracheostomy. This is a child who had laryngeal diphtheria and who is having a tracheostomy. There are the features. This is a child who looked as if he has got mumps. But when we open the mouth to see whether he has got inflamed Stenson's duct, what he had was severely carious. So these are alveolar abscess or a dental abscess, which can mimic mumps. So now it's over. I think I'll stop there, right? Okay. Can you all still hear me?
Yes, sir.
Yeah, in 10 minutes only.
Yeah.
Lecture. But during the month, if Nimali can find some slots, she might arrange a few more slide teaching sessions for you all. So when she notifies, you can link up like this, but come through learn, don't come through this 40-minute thing. Right? Okay. This I have already shown. This is anophthalmos. This is the same baby. This is that one. This is again a rare condition, but this is called a collodion baby. Why you called it a collodion baby is it's as if the baby has been wrapped in a small silly bag like thing. The whole the skin is stretched and shiny. So this is the mild manifestation of a congenital called congenital lamelliosis. We say corolla, that's common even in Sri Lankan children. It's not a serious. So these are collodion baby where the skin is highly stretched and shiny. So looks as if the baby is wrapped in a silly bag. This chickenpox I showed you already. The Burkitt's lymphoma. This severe dehydratation. This is the most severe form of that. Where it's the connective tissue contracture is so great that it splits open the skin. It causes extropion. This physical sign in the eye where the eyes get everted is called extropion. So this is called harlequin wave. The previous one was a collodion wave. This is called harlequin. Harlequin is Harlequin. Harlequin is a word used for a certain kind of clowns in circuses. Harlequin clowns. That is, they wear a patchwork uniform. They wear a dress made of different colors of different clothes called harlequin. So this particular condition is called harlequin fever. This was my patient. He lived till I left Saudi Arabia for 2.5 years, but he wouldn't have lived for very long. These are lamellic. These are treated with retinoids. You know, there is a group of drugs called retinoids. So when you give retinoids, these conditions normalize, but they are immune deficient and they don't live for very long. So it's a collodion baby and a harlequin baby. These are curiosities. So I told you in this slide set, these are not common. You will never see this in a short case in Sri Lanka. This I have already shown. This is also a rare condition in Saudi Arabia. What you can see is this child has had his eye completely enucleated. And this is tarsorrhaphy. The two eyelids have been sutured together. He has had a tarsorrhaphy done after enucleation. So only one indication, this child had what is the condition you had? What is the tumor? A retinoblastoma. Retinoblast, it's a hereditary tumor, autosomal dominant. So he has had a retinoblastoma and he had the eye removed and transferred. Sometimes it's bilateral. Luckily for this boy, it was unilateral. These I have already shown. Okay, all the others I have already shown. So that's it. So I went through all the slides there. So I'll finish the class today. So when Nimali picks up another class, you contact me and we'll have another slide discussion. Okay. Any questions? Can you still hear me?
Yes, sir.
Yes, sir.
Yes, sir.
Any questions or clarifications on any of the things we saw? Okay. All right. We'll wind up then, right? Okay. See you.
Thank you,
Thank you.
sir.
Thank you, sir.